it really started as a conversation between myself and a few of the other PIs, Jeff included, and then Jay Lemchenko and Roy Haggerty, Javier Nieto, and thinking through the testing shortage. And this was about 6-8 weeks ago, and trying to figure out what a university could do to support its community. I mean, we have a lot of qPCR machines, and that's a key machine involved in the test for the presence of the virus, and just trying to figure, and we also, as epidemiologists are aware of how important prevalence estimates are in terms of understanding just where we are in the epidemic, having the ability to forecast and plan, and trying to figure out how we could use the capacity of a resource of a university to help out. And so we just sort of started trying to put the pieces together, and that's what the TRACE project grew out of.
Jeff, from your perspective here, as you guys continue with this study, what did you want to get out of it?
Well, one, as Ben said, we want to be able to, provide information to the community, to the public health officials in the community, so they can use those results to control the pandemic, at least here, starting here in Corvallis locally. So that's been our primary objective all along, is to get that population-based estimate of the prevalence of infection in the community to really so public health officials can make informed decisions.
All right, to be clear here, Ben, because from what I read about this study, there's a testing component to it, but you guys were literally going door to door asking people to submit samples. Am I getting that correct? Like, I would imagine in some regard, like, it's kind of comforting, right? Because it's a test and you be included, you'll get to know where. I think a lot of people in this country would love to get tested, and there hasn't been ample testing. But at the same time, it might be a little weird, right? Like, someone knocks on your door and says, "Hey, I want to test you." So what was sort of the reaction from a lot of people in the community?
Sure. If I could break that question into two parts. Yeah. First, TRACE is a lot more than testing. It's a whole integrated system, and community engagement is at the core of it. And the door-to-door design, getting a representative sample of the community through community participation and through the field work of the field teams, that's the key. And so in terms of what it's like, I mean, we've had a really, really positive response from the community, and Jeff can speak more to this, but it's been really wonderful on the whole. Really high participation rate, up around 80%. And a lot of folks, just really enthusiastic and grateful. And the tests that we're doing, it's a self-administered nasal swab. So it's not the nasopharyngeal swabs that you see on TV. It's quick. It's totally painless. It's self-administered. So it's an easy experience from that side of things.
Is the accuracy as good then?
So sensitivity, the sensitivity, so if I can sort of break that down a little bit, I mean, the sensitivity of the test, sort of what's the rate at which we correctly identify folks who actually do have the infection. You can break that into a couple of parts. The first one is the technical sensitivity. So if there is virus on the swab, what's the chance that we'll detect it? And that sensitivity is very, very high. The test that we're using can detect even very, very small amounts of virus. Getting virus on the swab is another matter, and understanding the sensitivity of the test in this community surveillance context is actually not well understood. And that's across a range of tests and contexts, because what you need to do is take a bunch of known folks who are infected and then do the test, and that's difficult to do. So we're less certain on that side of things, but we're still confident there's value.
Jeff, you got this great background where you worked for the CDC, and in a lot of ways, you're really knowledgeable on what's currently happening in this entire country with regard to this pandemic. And not for nothing, you probably Monday morning quarterback this thing as well. So what are the things that you've gathered over the last couple of weeks here that have struck you as surprising in terms of the readiness of the nation?
Well, I mean, we are in unprecedented times here. So when I was at CDC, pandemic influenza 2009, pan flu was the height of that, and that planning for that. But that was a much different pandemic than what we're experiencing now. This is a very novel virus. But I think the approaches are similar in that we need to, everybody's heard the term flatten the curve.
Sure.
That is an important step no matter what type of pandemic we're experiencing. We want to be able to lessen the impact on the healthcare community so that they can appropriately treat and tend to people who are sick who do present in the healthcare system. So flattening the curve, I mean that's something that needed to be done. In terms of testing, again, this was a novel virus, and I think it just our infrastructure that was in place needed to be revised or adapted to get to appropriately roll out testing. I think we're still doing that.
Ben, Jeff sort of lays out some big picture items with regard to testing and how the federal government, in terms of being prepared, there's obviously some challenges when you're talking about a brand new virus. But back in 2014, Ebola, that was something from a scientific perspective that you were working on. Any similarities in terms of that process and what you're seeing right now?
Well, at a very high level, I think that pandemics or epidemics of infectious diseases they do share some similarities in probably in a couple ways. Very high level, I mean, everyone kind of goes into emergency mode, and emergency mode is different in a lot of ways. There are things that work well outside of emergency mode, ways of making decisions, ways of thinking that don't work very well in emergency mode. And I think that's been true, if I could just be that general. I mean, I think that's been true, I've noticed in both cases. I mean, in emergency mode, people are working 24/7 on the phone, making connections, making things work. And there's a big silver lining there. In both cases, we've experienced talking with folks and having doors open and working in ways that we wouldn't normally. And it's been productive. It's been encouraging. And so that's been true. That was true in both. And I actually, obviously the pandemic is awful, but that way of working is actually has some really positive elements to it. Exponential growth of an infection, whether it's Ebola virus or SARS-CoV-2, to control it, you need, in a sense, an exponential response. And that is trying to figure out how to do that and stay one step ahead of a contagion that's spreading in that exponential way is a monumental challenge. And so I think that is a commonality between the two as well.
Okay, so you're talking about this rapid spread of this virus. Jeff, you made reference to that phrase that everyone talks about, right? Flattening the curve. So testing is obviously going to be huge. The antivirals, and we've read about and heard about some of those, not to mention a vaccine, which still doesn't currently exist. Give me the everyday approach as government officials need to game plan, as universities think about getting their kids back on to campus for school. How do you contain something that Ben just described as sort of like this explosive rate at which this virus can spread?
Well, I think, extensive testing is going to be the key, so that we can quickly identify people who are infected with SARS-CoV-2 and then isolate them and then have rapid testing of their contacts to then stop the spread around that person. And that needs to be repeated for across communities to slow the spread is really the key here. Rapid detection, rapid isolation, quarantine of contacts, and testing of contacts is what really needs to be done to swat this thing down, so we can really get back to something resembling normal activities.
Jeff, I want to get back to the study because Ben gave me this high-level approach to what you guys wanted to accomplish here, and you mentioned as well, it's information, it's data. As the study continues to evolve here, what are these key components in terms of the findings and what's still left to be done?
In terms of we have 2 more weekends of data collection in Corvallis. So the goal is to identify snapshots in time, multiple snapshots in time of the prevalence of infection in Corvallis. And that's going to give us information to see how it's changing over time, which is really valuable. Single points in time can be valuable, but it's even more valuable is multiple points in time of that prevalence estimate. So that's what we're looking to do here in Corvallis. And then obviously we started this project with the hopes of creating a template that can be replicated in other communities. So that's still the goal, and we're looking into doing that.